Hello, ladies and gentlemen. Welcome to part 7 of our psychiatry review questions. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you very, very much who have already donated. All right, let's get started. So this is going to be 1 through 3 here. So we're going to run through 1, 2, and 3, and then we'll come back to our answers. And this is going to be really important because this is a topic that you're going to have to understand how to work through. So that'll come into focus as we go on. So let's start. A 23-year-old woman presents to the clinic complaining of intermittent depressed mood. She says that for the past few years, she's been on edge every time she's about to have her period, and then it goes away shortly after. These episodes are associated with bloating, breast tenderness, increased appetite, difficulty sleeping, difficulty concentrating, and a loss of interest in activities. She says, "I can handle the bloating and all that, but last time I went through this, I pushed my little brother and he almost fell down the steps." She denies suicidal ideation. She has a past medical history of migraine with aura, no past psychiatric history. She takes no medications. Her last menstrual period was 2 weeks ago. Vitals are within normal limits. Physical exam is unremarkable. TSH is within normal limits, and qualitative beta HCG is negative. Which of the following is the best next step in the management of this patient? A, menstrual diary. B, fluoxetine. C, valproate. D, aripiprazole. E, cognitive behavioral therapy. Or F, cognitive behavioral therapy and fluoxetine. Okay, let's go on to our next one. So 2 months later, she returns for follow-up and says, "I've been keeping track of my symptoms like you asked me to. Upon review of her menstrual diary, you note increasing symptom severity during days 23 to 28 of her cycle and decreasing severity days 1 to 3 with resolution by day 4. The same pattern is seen in both of the past 2 months. Which of the following is the best next step in the management of this patient? A, bupropion, B, fluoxetine, C, lamotrigine, D, levonorgestrel phenylestradiol, E, leuprolide, or F, topiramate." So you can kind of see here how we're working through this patient. You need to kind of have this idea of how the process works, right? Because they will ask you about that, especially on step 3. Very, very important. It's not enough to know what's the right answer, what's the best next step. You need to know what the correct order is. Okay, let's go on to 3. 8 months later, the patient returns. She says, "When you adjusted my dose last time, it worked a little bit, but I still feel depressed during the usual time, and I eat a ton." She is currently on the maximum dosage of fluoxetine. Vitals are within normal limits. Physical exam is unremarkable. In addition to discontinuing fluoxetine, which of the following is the best next step in the management of this patient? A, aripiprazole. B, levonorgestrel phenylestradiol. C, copper intrauterine device. D, paroxetine. Or E, lamotrigine. All right, I'll let you pause here. You can go back and look at the other ones if you want. Remember, you're going to have about an average of 1.5 minutes per question on the USMLE. You want to lock in your answer though a little sooner than that, unless you're working through one of those where you have to answer 1 before moving on to 2. Then take your time, but you want to make sure you get an answer in there. I would say within a minute, 45 seconds, a minute, and then flag it if you want to, then come back and review. You don't want to spend 3 minutes on one question and then be scrambling, right? You know that. You've all taken the MCAT. You've probably taken step 1. So let's go ahead and look at the answer to question 1. So the answer is a menstrual diary. All right. So she pretty clearly has either PMS or PMDD, but we can't make that diagnosis based on the patient's stated history alone. And the answer to why that is because the answer to the treatment for PMS or PMDD is medication. And we don't want to throw a medication every time someone says, "Oh yeah, my periods suck." Well, yeah, periods suck, but that doesn't mean you have PMS, right? There are specific criteria for PMS and for PMDD. So just having, bad mood during your period is not necessarily enough to make the diagnosis. So what we have them do is a menstrual diary. Okay, and that gives us a more objective way of looking at these symptoms, because, if she's having these symptoms 2 weeks after her period, and then, maybe they coincide with the period, but she's having all these symptoms at other times, then we might need to look a little bit deeper into possibly a major depressive disorder. Now, that being said, if you fit the criteria for major depressive disorder, that is always the diagnosis, okay? Even if you have PMS, if you fit the criteria for major depressive disorder, that is the diagnosis, all right? But we don't see that here. Well, yeah, we see some difficulty sleeping, change in appetite, difficulty concentrating, loss of interest in activities, but they are not 2 weeks, okay? That's important for you to know. For major depressive disorder, okay, the symptoms have to be at least 2 weeks, and that is not going on here. This comes and goes and comes and goes, and it doesn't last that long, okay? It starts maybe a little bit after or a little bit before her period starts, and then a little bit after. That's not 2 weeks, okay? So if we were seeing here that she's having, this every month where it comes on for 2-3 weeks, then we would go for major depressive disorder. But that's very important here that that major depressive disorder has to be 2 weeks, and it can't be this sort of intermittent thing, especially if it's coinciding with the menstrual cycles. And this is a big reason why we do this menstrual diary, because it will help you distinguish this from major depressive disorder, because they can have 5 Siggy Cap symptoms, but it doesn't last 2 weeks, so it's not major depressive disorder. The rest of these, fluoxetine, we could do, but we have to confirm PMS, PMDD. None of the rest of these would work. Cognitive behavioral therapy might be good in addition to the medications if we have to, but that's typically for major depressive disorder, as is that. All right, let's go on to question 2. So we have diagnosed her with PMS, PMDD, probably PMDD based on how she treated her little brother. Mood swings being very important with PMDD, distinguishing it from PMS. But what we see here is increasing symptom severity, days 23 to 28, decreasing severity after the period, and resolution by day 4. So this is not going on for more than 9 days at a time. So again, not major depressive disorder. However, with a diagnosis of PMS or PMDD, the treatment is an SSRI, okay? Fluoxetine is the only SSRI. It is actually the most well-studied. That's the one I would go to first. I don't think you'll be asked to pick fluoxetine, paroxetine, sertraline, and so forth, but do know that fluoxetine is the most studied and probably the safest. Bupropion, that's for depression. That would be something you would go to after you've tried 2 SSRIs. Some doctors for depression will do it earlier than that, depending on the presentation, but this is not appropriate in this patient. She does not have major depression. She's got PMDD. Lamotrigine would not be helpful. Levonorgestrel, ethinyl estradiol. Okay, so you take 2 SSRIs. All right, you've taken one, you failed it. You've taken a second one, you failed it. Well, the next thing that you would do in this patient would be either oral contraceptives or Leuprolide, GnRH agonist. Now, why can't this patient, let's say she'd tried a second one, still hasn't gotten any better. What could we use levonorgestrel, ethinyl estradiol in this patient? In most patients we could, but not this patient. And why is that? What here tells us we can't use oral contraceptive pills? History of migraine with aura. Migraine with aura, no contraceptives. Okay, no oral contraceptive pills, no hormonal contraceptives. They can be on a copper intrauterine device. That would be just fine, but no OCPs. Leuprolide. Now, that would actually be the drug we would go to in this patient if she failed 2 SSRIs. The problem with Leuprolide, the reason we don't go to it unless we have to, is because it basically induces menopause. So we really want to avoid that. And then topiramate, would not be useful for PMS, PMDD, but it could be a good drug to go to if she had bipolar disorder. And the reason for that is because it would help with the migraines too. Topamax is used very commonly for migraine prophylaxis, but it is not used in PMS, PMDD. You will always start with an SSRI. If they fail one, try another one. If they fail that, you can go on to OCPs or leuprolide. Make sure you know the contraindications and the adverse effects. Okay, so question 3 gets into what I was telling you about. So she started on the medication, adjusted the dose, worked a little bit, but she's still feeling depressed and she's eating a ton and she's on the maximum dosage of fluoxetine. Okay, what we do here is switch SSRIs. Okay, paroxetine. We're not going to use an antipsychotic. We talked about why she can't use that. Copper intrauterine device does not stop menstrual cycles. It only prevents implantation. And lamotrigine, we talked about that. Okay, now, let's say you were dealing with a patient who looks just like this, but they had major depressive disorder. Then what would you do? So if you've got a patient with major depressive disorder who's responding a little bit, but not completely, and here I'm talking major depressive disorder, not this patient. So they responded a little bit, but not completely. We call that a partial responder. And the next step would be to augment. Okay, we would add something like bupropion or usually bupropion. Buspirone would be another one you could add. Okay, you would not do 2 SSRIs though. Okay, so this is getting at the difference though with PMS, PMDD. If they fail an SSRI, meaning they don't get any significant response at all, then your next step is to switch to a new SSRI. Okay, so it's a little bit of a difference in treatment in management. So let me write that down here. Major depressive disorder, start SSRI, partial response, augment, no response, different SSRI. Apologize for my handwriting here. I guess what they say about doctors is true. Okay, PMS, PMDD, SSRI, and partial response or no response, a new SSRI. Okay, and of course, that's if they're at maximum dosage. So you can always increase the dose, and then if you're at maximum dosage and you're not getting the response, then you do what you need to do. With PMS, it's going to be a new SSRI. With major depressive disorder, if they're partially responding, augment. If they're not responding, start a new SSRI. Okay, so I want you to know the difference between that because that could come up. So here you have PMS and PMDD. The big difference with PMDD is that is actually in the DSM-5, so there are criteria for that. You can look that up on your own, but what this will, it's not a huge, it's not a huge deal if you know the difference between the two. Because the treatment is the same. But it is good to know with PMDD, the symptoms are just more severe. They cause significant functional impairment. So with PMS, they can go to work, they can do all the things they need to do. They're just not really happy. With PMDD, they're getting into fights, they're having major mood swings, they're having relationship problems, they're having trouble at work, they're having trouble sleeping. That is where the difference comes in. Usually you'll hear it in mood swings, but just really look for that functional impairment, okay? So recap, menstrual diarrhea is the first step. Once that confirms PMS, SSRI. You fail the SSRI, try another one. Fail 2 SSRIs, contraceptives or leuprolide. Go with contraceptives if you have to choose, but if the patient has contraindications for contraceptives, and you should know what those are, then you go with leuprolide. And then one thing to note here with complications, there is an increased risk for mood or anxiety disorders, and many of these patients will have a history of that to begin with. Okay, here's a really big one, and 4, 5, just 4 and 5 are going to be linked together. Okay, so we'll start with this one. An 8-year-old boy is brought to the clinic by his parents complaining of behavioral issues. For the past year, the parents have received multiple phone calls from his school saying that the patient speaks out of turn and often argues with teachers throughout the day over trivial matters. One teacher said that after she put him in timeout, she returned to the room and found that he had drawn a crude picture of her and was encouraging other students to laugh. At home, the parents say he refuses to do his chores and instead likes to annoy his 13-year-old sister when she's doing her homework. When the father removed the video game console from the home, the patient threw a temper tantrum. When asked how school is going, the patient says, "I hate school, the rules aren't fair, my teachers make me mad, and if they were nicer to me, I wouldn't get mad at them." When asked if he has any friends, the patient says, "No." The mother says, "He used to get along with the neighbor boy, but he stopped coming over because he gets mad so easily," that being the child, the patient. She then breaks down into tears. "I don't know what made him like this. He was such a happy boy growing up, and now he's always angry and upset. Last time he got mad at me, he hid my purse, and it made me late for work. I just want my little boy back, you know?" Birth history, uncomplicated. Patient has met all age-appropriate milestones. He's got no significant past medical or psychiatric history. Vitals are within normal limits. Mood is irritable. Affect normal. Thought process logical. Insight is poor. No hallucinations or delusions. Which of the following is the most likely diagnosis in this patient? A, adjustment disorder with disturbance of conduct. B, oppositional defiant disorder. C, conduct disorder. D, attention deficit hyperactivity disorder. Or E, age-appropriate behavior. Okay, so go ahead and choose your answer there, and we're going to move on. All right, after discussing the diagnosis and treatment plan with the parents, the mom asks if he's going to be like this when he's an adult. She says, "I read on Reddit that kids like him grow up to be criminals." After acknowledging the mother's concerns, which of the following is the best response to her question? A, it's likely that he will develop antisocial personality disorder, but the risk goes down with proper treatment. B, it is likely he will develop conduct disorder, but the risk goes down with proper treatment. C, it is likely that this disorder will resolve by adolescence or adulthood. D, it is unlikely that this disorder will ever resolve. Or E, it is likely that this disorder will resolve on its own as long as he takes the right medications and attends counseling sessions. Okay, let's go ahead and answer 4. So 4 was the question of what's the diagnosis. This is oppositional defiant disorder. Okay, so you have 3 disorders that you probably confuse a lot. Oppositional defiant disorder, conduct disorder, and antisocial personality disorder. Okay, how do you keep these straight? So first of all, if you go in these orders, this is roughly the ages you encounter them in. So oppositional defiant disorder is going to be usually your grade school students, maybe early middle school. Conduct disorder is usually going to be middle school, high school, and antisocial personality disorder is adults. Okay, we never diagnose personality disorders in children. All right, so oppositional defiant disorder, I like to think of this as the brat, okay, the naughty kid, the kid that's always getting into trouble. You know who I'm talking about. If you went to elementary school, you know exactly the kids I'm talking about. They weren't criminal children. They weren't setting fires to anything, but they talk back. They push and shove, they scream, they throw temper tantrums, they're always going to the principal's office. That is oppositional defiant disorder. Conduct disorder, on the other hand, is the juvenile delinquent. Okay, these are kids that are possibly getting into legal problems. Typically, this is going to be older because 7, 8-year-olds aren't really getting into legal problems. Although, you know, with our cops nowadays, they like to make everything a legal problem. But these are kids that are bullying. They're getting into fights at school. They're fist fights. They're maybe stealing. This looks a lot like antisocial personality disorder, but a little bit more mild and in children. And then antisocial personality disorder, this is the psychopath. Okay? Now, Why is this not an adjustment disorder with disturbance of conduct? So adjustment disorders, the symptoms there has to be a life stressor. Okay, that can be a lot of things. It could be moving, parents getting divorced, death of a pet, starting a new school, so forth. That's got to be there. We don't see any of that here. Then what we need to see is symptoms developing within 3 months of that stressor. We don't see that here. And it's got to go away within 6 months of the stressor. Okay, this has been going on for the past year, so it's not an adjustment disorder. Conduct disorder, we talked about that. That's the delinquent. This boy's not a delinquent, he's just a brat. ADHD, well, he's got some ADHD features, and there's a lot of comorbidity between oppositional defiant and ADHD. But what we see here is not only issues with school and with the teachers, but it's not attention related. He's not talking out of turn. He's not getting distracted. He's not having difficulty with his homework because he can't sit still. That's what we see in ADHD. Okay, so he's having these problems in 2 domains, at school and at home, which we would expect with ADHD, but that's where the similarities end. What we're seeing here is a pattern of bratty behavior. Okay, and I mean, I know that's not a medical term, but it really helps, okay? He's just a brat. He's not doing his chores. He's arguing with his teachers, and when he goes to timeout, the teacher's gone. He's drawing crude pictures and encouraging others to laugh. That's vindictiveness. That's something we see in ODD. He's throwing a temper tantrum. He's quick to be angry. And you see this come up. You see this a lot with ODD. The parents will describe them. He's so angry. He's so mad all the time. He just fights. That's ODD, okay? And I'll show you some of the criteria. And no, of course, this is not age-appropriate behavior. It's pretty safe to say if it's affecting them at school and at home, and it's been affecting them for a long time, it is not age-appropriate. Age-appropriate behavior does not cause impairment in functioning, and that is what we see here, impairment in functioning. Okay, now the answer to question 5, believe it or not, is that this disorder will likely resolve by adolescence or adulthood. So only about 30% of patients with ODD go on to develop conduct disorder. And a minority of those patients will go on to develop antisocial personality disorder. So the prognosis is good. It's likely that it will resolve. 70% will resolve by adolescence or adulthood. Okay, so antisocial personality disorder, probably not going to happen. It could. Antisocial personality disorder patients tend to start out with ODD, then graduate to conduct disorder, but that's not necessarily going to happen here. It only happens in a minority of cases. Likely he'll develop conduct disorder. No, we talked about that. Unlikely this disorder will ever resolve. No, we talked about that again. It's likely this disorder will resolve on its own. True, as long as he takes the right medications and attends counseling sessions. Well, attending counseling sessions would be good. It's part of the management, but medications are never part of the management for oppositional defiant disorder, unless they have comorbid ADHD, which we did not see in this patient. So oppositional defiant disorder, these are mad, bratty kids. They like to argue, they're vindictive, they're angry all the time, they like to argue with adults, okay? Kids arguing with each other, not a big deal. Kids arguing with their siblings, not a big deal. When it's parents, authority figures, adults, that's a problem. Deliberately annoys others, we saw that in this patient, right? So he likes to annoy his I should have probably highlighted that, annoy his 13-year-old sister when she's doing her homework. Blames others for their own mistakes. So he's getting in trouble at school and he's blaming his teachers. He's saying if they weren't mean to me, I wouldn't get mad at them. Well, are those teachers mean to him? We have no evidence of that. Some teachers might be genuinely mean, but that's probably not the case here. Easily annoyed, angry, resentful, vindictive. Okay, so I bolded the sort of buzzwords that you'll want to know, and this can't be due to another another mental disorder. So oppositional defiant disorder is rather low on the hierarchy of psychiatric disorders. Parent management training and psychotherapy. Okay, that's it. So family needs to be involved. If you see the word family therapy, that's good too. There's no pharmacotherapy, but make sure you're looking out for comorbid psychiatric conditions because there's a fairly strong association between ODD and ADHD. Like I said, 30% go on to conduct disorder. This is conduct disorder. I'm not going to read through all this because this was only on ODD, but I included it here, and hopefully in the future I can do more questions on these ones. Okay. Okay, so 6 through 8 are going to come together. We're going to follow this patient over the course of a couple years and see how different ways that some of these things can present in the same patient. Okay, an 18-year-old man presents to the clinic in February complaining of depressed mood for the past 4 months. Shortly after moving across the country to attend college, he says he began losing interest in the extracurricular activities he signed up for, things he usually enjoys doing, including soccer and violin. He says, "My mom developed breast cancer shortly before I left. She's doing okay and everything, but I feel like a bad son for not being there." He continues, "My grades are good and I'm able to focus in class, but I sleep like all the time. And last week I was late for class, but my professor let me off with a warning because it's the only time it happened." He's gained 2 pounds since his last visit for pharyngitis previous November. He denies suicidal ideation. He doesn't drink alcohol, smoke, or use recreational drugs. He has a past medical history of celiac disease controlled on a gluten-free diet. He doesn't take any medications, no significant psychiatric history, including mood episodes. Vitals are within normal limits. Physical exams are unremarkable. Mood is depressed, affect flat, thought process logical, insight good, no hallucinations or delusions. Which of the following is the most likely diagnosis in this patient? A, major depressive disorder. B, persistent depressive disorder. C, seasonal affective disorder. D, adjustment disorder with depressed mood. Or E, normal stress reaction. Okay, so let's go ahead and move on to 7. 3 months later, the patient returns to the clinic. He says, "My mood hasn't gotten any better. I'm still sleeping all the time, and I missed a test last week. Now I got to repeat my calculus course. I would have had to repeat it anyway because my grades are terrible. I can't focus." He continues, "My sister and brother and everyone else is there for my mom, but I'm not. My mom says she's fine, but I'm thinking about dropping out because I feel useless." Despite your encouragement to him at the last visit to re-engage in activities he enjoys, he says, "I don't care about that stuff anymore, and neither do my friends. I'm too tired for it anyway. The violin is hard work, and I'm too out of shape to play soccer." He continues to deny suicidal ideation. Since his last visit, he's lost 15 pounds, and he responds, "Campus food sucks, but I'm never hungry anyway." Past medical and psychiatric history are unchanged. Vitals are within normal limits. Physical exams unremarkable. Mood is depressed. Affect flat. Thought process logical. Insight good. No hallucinations or delusions. Which of the following is the best next step in the management of this patient? A, prescribe bupropion and refer for psychotherapy. B, prescribe sertraline and refer for psychotherapy. C, refer for psychotherapy. D, inquire about family history of major depressive disorder. Or E, prescribe sertraline and inquire about childhood history of attention symptoms. And I apologize to you. I have a major tension headache right now. So if you hear an abrupt change in my tone of voice, it's because I had to pause. All right, let's move on to 8. 2 years later, the patient returns to the clinic for follow-up. He received proper therapy according to his diagnosis. He said he's still seeing his therapist, but stopped taking the medication several months ago because he was feeling better. He says, "I don't want to take pills anymore, but I read that I shouldn't stop the pills you gave me right away, so I started cutting the tablets in half and took that for a week, and then took half a tablet every other day." He says he's feeling good now, but is concerned because he's been eating a lot lately because he's so stressed out. When asked about how things are going, he says, "These past couple months, I've been feeling so burnt out, like all the time. I started quantum mechanics a few months ago, which is really hard, you know? And to make matters worse, my girlfriend cheated on me last month, and it's just been a lot all at once, you know?" He says he plans to start the violin again soon, but hasn't gotten back to playing soccer because he doesn't have the time. His mother recovered from breast cancer, and he talks with her regularly on FaceTime. She's coming to visit next week. He says, "I know I'm going through a rough patch right now, and I'll be okay. My sleep is good, and I feel like I've got more energy than the last time I saw you." His weight is unchanged from his previous visit. Vitals are within normal limits. Physical exam is unremarkable. Mood is stressed. Affect congruent to mood. Thought process logical. Insight good. No hallucinations or delusions. Which of the following is the best next step in the management of this patient? A, reassurance. B, restart sertraline. C, recommend another therapist. D, TSH levels. Or E, follow up in 2 weeks. Okay, let's go back to 6. So this is adjustment disorder with depressed mood. Now, adjustment disorders, here's how it works. All right, so here's months, 0, 1, 2, 3, 4, 5, 6. So there's a stressor. Okay, that can be a lot of things. He's got 2 of them. He moved across the country, mom had breast cancer. Okay, anything that might make you stressed out is a stressor. Moving across the country, a relative dying, a pet dying, you name it. I mean, lots of things. Getting married, getting engaged, even happy things can be stressors. Anything that you have to adjust to, life changes, okay? Keep a very low threshold for that. Okay, so there's a stressor. Symptoms have to develop within 3 months of said stressor, and they have to resolve by 6 months. Okay, and there are a lot of different adjustment disorders. Adjustment disorder with depressed mood is probably the most common, but there's also adjustment disorder with a conduct disturbance and things like that. So you don't need to know that. Just know adjustment disorder. They're not going to ask you the different kinds, and if they do, you'll know which one it is. Okay, I mean, it says depressed mood. All right, so major depressive disorder. Why not? 1, 2, 3. 3 SIGI CAP symptoms. Is that enough? No, gotta have 5. Persistent depressive disorder. It's been going on for 4 months. How long do you need for persistent depressive disorder? 2 years. Seasonal affective disorder. Okay, so it could be. Granted, this started in October and it's February. However, when you get a question on seasonal affective disorder, what they're going to tell you is that this happens at the same time every year, and they cannot fit the criteria for major depressive disorder. So it's like a dysthymia, but it only happens at specific times of the year, and it's winter. Okay, now that could be October through March in the Northern Hemisphere, which is what you'll get on the USMLE. But if you're down there in Australia and upside down land, you know what time of year winter is for you, right? So it's not seasonal affective disorder. And normal stress reaction. So a normal stress reaction does not cause impairment in functioning. Impairment in functioning, again, keep a very low threshold for that. Anything that could cause a problem. So right here, being late for class. That's it. That's an impairment in functioning, no normal stress reaction. Okay, so what's going on here? So his mood hasn't gotten any better. This is 3 months later. Still sleeping all the time. Still can't focus, decreased concentration, feels useless. That's up there with guilt. Doesn't care about that stuff anymore, loss of interest, too tired, loss of energy, and he's never hungry anyway. Okay, so right there, that's 6. And this has been going on for 3 months. He is now major depressive disorder. Now, was this medical malpractice? No. You correctly diagnosed him here, and you didn't send him home with SSRIs, as you shouldn't. That's for major depressive disorder, or PMS, as we saw earlier. Okay, so you did the right thing, but he came back, and he's depressed now. He fits the criteria for major depressive disorder, and as we know, the best treatment for that is SSRI and psychotherapy. Okay, the 2 of them together is the most effective, but if you can only do one, that's okay. Okay, some patients don't want to take pills. They'd rather talk to somebody. Some patients don't want to talk to someone. Just give them the pills. I'm going to say women and men are very different in that regard. So why not prescribe bupropion? So bupropion is a good antidepressant. On your exam, you're probably going to start with an SSRI, but there's a good reason why we don't want to use bupropion in this patient. He's lost 15 pounds. Bupropion is a more stimulating antidepressant. And you could make an argument for that because he's sleeping all the time, but bupropion is, on your exam, not going to be the drug you go to. Okay, it's not going to be the drug you go to. You're gonna go for an SSRI. Bupropion won't be the answer until you either need to augment an SSRI or you've tried 2 SSRIs and they've failed. Okay, but in practice, you do see doctors going straight for bupropion. I'm going to tell you that. If you've seen that in practice, that's fine, but that's not the right answer for your exam. Refer for psychotherapy? No, we need both. Inquire about family history of major depressive disorder? It doesn't matter. He's got it. Prescribe sertraline. Inquire about childhood history of attention symptoms. Does he have ADHD? He might, but it's a little premature for that. Let's treat his depression and see if his attention span gets better. Okay, because we know attention can be a problem in ADHD, but we also know it's a problem in major depressive disorder. So if we treat the major depressive disorder and that gets better, we're not worried about ADHD. If his mood symptoms all go away, he's interested in things, he feels good about himself, he's got energy, he's eating right, and the only problem is he can't focus, then we start thinking about a childhood history of attention symptoms. And why do we need to know childhood history? Because ADHD has to start in childhood. Okay, now that said, you can make a retrospective diagnosis by all means. Okay, not everyone gets to see the doctor when they're kids. That shouldn't exclude them from a disorder that they may have very well had when they were a child. But there has to be an onset in childhood. So this would be what you would do here if he responds to the antidepressant and he still has issues paying attention, focusing. Okay, so now we go on to 8. So what's up with him now? So he's feeling better. He stopped taking the pills. Okay, so, you'd really like for your patients to tell you before they stop medication, but some patients just, they don't care. They're going to do it on their own. Well, he did it the right way. Got to give him credit, but, you should probably let him know, hey, if you're going to stop your medication, give me a heads up, right? Okay, so, this guy's clearly doing his homework. All right, so he stopped the pills. He's still going to psychotherapy, so that's great. He's eating a lot because he's stressed out. He's feeling burnt out, but what else? He's going to start the violin again, so his interest is better. His sleep is good. He's got more energy. His weight is unchanged. He is no longer depressed, okay? He is controlled on psychotherapy. However, he is stressed. Is this an adjustment disorder? He just started with quantum mechanics, and his girlfriend broke up with him. That's certainly a possible trigger for adjustment disorder. And the answer is no. He doesn't have any impairment in functioning here, and you have to have impairment in functioning to be adjustment disorder. Okay, if you're not fitting the SIGI-CAP symptoms, you're not depression, you're not adjustment disorder, you're not impaired, you're not having any problems with school or with work or with your relationships, then the answer is a normal stress response. And we all know what it's like to be stressed. You got an exam coming up and maybe you're not eating right and you're nervous and you're not sleeping right and maybe difficult to focus. You know how things get when you're stressed out. Not all stress is pathological. Stress can be normal, okay? And that's what it is here. That is normal stress, okay? But they can't have major depressive disorder. Okay? If they fit the criteria for major depressive disorder, then it's depression. He doesn't fit that here. So we will not restart sertraline. We're not going to recommend another therapist. He's well controlled just by seeing this therapist. She's doing a good job, or he's doing a good job. TSH level. He doesn't have any symptoms of hypothyroidism, and he's not depressed. Now, TSH level is good to get as part of your routine workup for any patient you're diagnosing with a mood disorder, because hypothyroidism can cause depression. Hyperthyroidism can cause mania, and you want to know if it's a thyroid cause because the treatment is completely different. However, that's not useful in this patient. He's just stressed. So while his cortisol level may be high, his TSH level will not be. Follow up in 2 weeks? No, he doesn't have symptoms of major depressive disorder. This is clearly a normal response to stress, and the treatment is reassurance. So here you have it. We talked about all these things. We didn't talk about persistent depressive disorder as much other than 2 years. You got to have at least 2 of those SIGI-CAPS symptoms, absent suicide. They're just persistently blue, okay, but they never fit major depressive. Adjustment disorder with depressed mood. Onset's got to be 3 months with an identifiable stressor, and it's got to go away within 6 months thereafter. Okay, can't meet the criteria for major depression. Normal stress response, we talked about. Big thing is not excessive and no significant impairment. Okay, question 9. A 9-year-old boy presents to the clinic with his mom because he's barely ever hungry. This started 3 months ago when he was diagnosed with attention deficit hyperactivity disorder by another provider who prescribed methylphenidate extended release. She says he's been doing so much better in school and he does his chores as soon as he's reminded. His teachers say he's a star student, but he's just not eating. He eats breakfast, but then comes home with his lunch barely eaten. He doesn't even eat his cupcake, and he loves cupcakes. He eats a small amount of his dinner, but shortly before bed, he wants a snack. I'm worried he's not growing properly. Review of charts indicates a stable weight. Birth history, uncomplicated. Patient has met all age-appropriate milestones. He has no significant past medical history or psychiatric history. Vitals are within normal limits. Physical exam is unremarkable. Which of the following is the best next step in the management of this patient? A, switch methylphenidate extended release to methylphenidate immediate release twice daily. B, decrease methylphenidate dosage. C, discontinue methylphenidate on weekends. D, switch to dextroamphetamine. Or E, switch to guanfacine. Okay, let's go ahead and answer this one. The answer is to switch from ER to IR. Okay, so that's a tough one. But you can kind of rule out these other ones. So the problem is here, he has got ADHD. His symptoms have resolved, but he's having appetite suppression. Very common adverse effect, practically universal. Everyone who goes on an ADHD drug, on a stimulant, is going to have a little bit of appetite suppression. For most people, it's not a big deal. Okay, if you're a healthy weight, you can probably, if you lose 5 pounds, not going to be a big deal. Some people really like that adverse effect. It's a welcome effect, but in children, it can be concerning because children are always supposed to be gaining weight. Look at a child's weight chart, it's going up. It's not staying level, it's not going down, it's going up. Okay, so they should be gaining weight. Now, the fact that he has, his weight is stable, well, 3 months, maybe his weight won't change a whole lot. So, we're not so worried here about this being severe appetite suppression. Okay. Now, if we decrease the methylphenidate dosage, what would happen? His ADHD would come back. Okay. He's doing fine on this medication. Discontinue on the weekends. Okay, so this is not going to help us. The reason it's not going to help us is because he needs to eat healthy throughout the week. Okay, he needs to be getting food throughout the week. Getting it on the weekends, it's not going to help if there's severe appetite suppression anyway, or even moderate appetite suppression. So this is something that you might do. You might discontinue it on the weekends if they're getting a little older. Let's say he's 12, 13 years old. He's starting middle school. And you want to see, well, maybe the ADHD is resolved, because it does resolve over time in many cases. So you might stop on the weekends and see how he does. Maybe set him down to do his homework and see if he can do it. Okay? Or you could discontinue, for instance, in this patient, you might discontinue in the summer. Okay? These are called drug holidays. I don't think you're going to be asked about drug holidays on your exam. Okay, so I would cross this out. Ask me below, though, if you have any questions on this. Switch to dextroamphetamine. No, methylphenidate's working. Dextroamphetamine has the same side effect profile. Switch to guanfacine. No, premature. Okay, so here's how it works. I'm going to draw here time and appetite suppression. Actually, I'm going to do this a different way. We'll do drug level. Be a little less specific. Okay, so how does it work with the extended release? So extended release with methylphenidate is usually 20 milligrams. You take it in the morning. Okay, so here's when you take it. And you get this nice gradual, and then it tapers. Okay. And let's just say here is wake, and here is sleep, ideally. Okay. Now, when you are up here, let's say like this, appetite suppressed. Okay. And it's only until you get down here at these levels here that you start to have an appetite again. So as you can see here, what's happening is you're feeding him breakfast. Okay, good. He's got an appetite. But then during lunch, no appetite, no appetite, no appetite. Even during dinner, no appetite. But he wants a snack before bed because his levels are finally coming down. Okay, so he's hungry before the medication. He's hungry after it wears off. But we want him to be hungry for dinner and hungry for lunch. So how do we do that? Okay, well, let's try this again. So T level. So let's say you gave him a dose of immediate release, so 10 milligrams of immediate release in the morning, and which wears off faster because it's immediate release. And then you gave him another 10 milligrams after lunch. Yeah, so this is working good. So now what you can see here is that he will be hungry for lunch, he'll be hungry for breakfast, and he might have a little hunger for dinner, maybe a little later, but, you know, we're doing a lot better here, okay? So when you're dealing with a patient with appetite suppression and ADHD, you want to optimize the timing of their medication first, because that way you can keep them on the same medication and just kind of work around it. All right, now, extended release is good for adults because adults, we can tell ourselves, okay, we have to eat. All right, but with kids, it's not as easy. Kids don't realize they have to eat until they're hungry. Okay, or you give them a cupcake, I guess, maybe. But even this kid wasn't eating his cupcakes, right? So that is why we would switch. And I don't know where... I can't leave. What is going on? There we go. Okay. Still figuring out this iPad. All right, let's move on to question 10. A 27-year-old woman presents to the clinic for pre-employment physical examination. Until recently, she's been working as a graphic designer from home, which she had done for the past 5 years. Recently, she'd been promoted and is making twice as much money doing the same thing, but in an office setting. She says, I really hate socializing and I'm not happy about it. I like to be alone. The only reason I accepted the promotion was because I needed more money for my video game console. After you congratulate her on the new job, she says, yeah, thanks, but I'd rather not be working in offices with all those people. The patient lives alone and has no interest in living with anybody else. While she's occasionally sexually active, she says they're just one-night stands and she has no desire for a long-term relationship, saying, I'm just happy being alone. I don't like to be around people if I don't have to. She has no significant past medical or psychiatric history. She takes no medications. Vitals are within normal limits. Physical exams unremarkable. Mood is fine. Affect flat. Thought process logical. Insight good. No hallucinations or delusions. She asks you, is this going to take all day? I want to go home. Which of the following is the most likely diagnosis in this patient? A, major depressive disorder. B, persistent depressive disorder. C, schizotypal personality disorder. D, schizoid personality disorder. E, avoidant personality disorder. Or F, social anxiety disorder. Okay, so another tough one, but you got to know your personality disorders, okay? So what you got here is the happy loner, okay? She likes to be alone, and she's okay with it. She doesn't like to be around people, and she's okay with it, all right? She just doesn't like to be around people. She doesn't hate people. She just doesn't want to be around people. She likes to be alone, and that's it. That's schizoid personality disorder. That's it. All right. Major depressive disorder. She doesn't have any of those signs. She's fine. She's probably not going to be pleased going to work, but that's situational. Persistent depressive disorder. She doesn't have any depressive symptoms at all here. Schizotypal. Okay, so this gets confused a lot. Schizotypal, schizoid. So the way I like to teach this to students is schizotypal has the positive signs of schizophrenia. So those are not frank, bizarre delusions and hallucinations, okay? But something along those lines, like odd beliefs and, stuff like that. Whereas schizoid personality disorder has more of the negative symptoms you see in schizophrenia. Isolation being the big one. But they don't have hallucinations. They don't have delusions. Okay? They just like to be by themselves and they're happy that way. That's schizoid. Avoidant personality disorder. So there's a little bit of overlap here in that they avoid being around people. But with schizoid, they aren't around people because they don't want to be around people. Avoidant personality disorder, they're not around people because they're afraid to be around people. Okay, they're afraid of being judged, they're afraid of being criticized. But it does not cause necessarily anxiety, and that's these two can get confused very easily. And I should do a question. I will probably do it on my next video that will help you tease these out, okay, because it can be complicated. Social anxiety disorder, these patients want to interact with people, but they get nervous. Okay, it's not even, I just don't feel like I'm good enough to be around other people. That's avoidant personality. Social anxiety is, I'm a good person and I could be friends with someone, but dang it, I just get so nervous every time I have to give a speech or talk to people or socially interact. Happy hour at work is like the worst thing ever. That's what you're going to deal with social anxiety. Look for physical symptoms, palms sweating when they're talking to people. Okay, so that's schizoid. So here's schizoid. 4 or more of the following. Really, don't memorize this. Just know what these patients look like. If you know that, you're good to go. So doesn't want or enjoy close relationships. They choose solitary activities. They usually don't have a lot of friends. They're indifferent to praise or criticism. So look at this. You told her, congratulations. I mean, she should be thrilled, right? I mean, she's making twice as much as she was doing the same thing. And she was making a good amount before. I mean, she's living on her own. So, she should be thrilled about this. You congratulate her and she's like, yeah, thanks. That is indifference, it's detachment, it's flattened affect. You see all those with schizoid. Very similar, again, to those negative symptoms you see in schizophrenia, but they don't have the delusions, and that's why this excluder here, exclusion criteria, says it cannot occur during the course of schizophrenia, mood disorder, psychotic features, or any other psychotic disorder. It also can't be autism, okay? And the treatment is cognitive behavioral therapy. I'm just going to tell you, people with personality disorders, it's always egosyntonic, almost always egosyntonic. Certainly in schizoid, it's going to be egosyntonic. They don't have a problem with it. So most of the time, you don't need to do any treatment. However, there will be times when they may come to you saying, I think I need help. Because maybe she goes to the office and she's got to talk to people. Or she gets written up because she's not friendly enough. And she's going to come to you and say, this is causing me trouble. Now it's no longer egosyntonic. Now you go for treatment. So here's your nice quick way of associating personality disorders.